Good morning, everyone. Today I'm Dr. Asif Almas. Today we are going to discuss about carcinoma of stomach. Now, you already have seen a lot of theoretical presentations, I'm sure, by now. But recently, I've just finished one professional examination, the final prof, and I have seen that most of you are very confused about how to write the long case. What are the important points you should add, and what are the important points that you should not leave behind? Definitely, you can customize, you can personalize the way you write it. But today I'm going to discuss a bit about how you are going to present a long case. I think that would be more helpful to you guys. So I'll be starting my PowerPoint presentation. Okay. I hope you can see.
Yes, sir. Presentation is on, sir.
Okay. Thank you. Thank you. So today we are going to discuss a long case of carcinoma stomach. This is actually a case which I have seen myself, and I'm sort of gonna describe how what I have seen. It's a very nice case because it has got all the aspects. It touches all the aspects of a long case and clinical examination as well. The patient had a lot of clinical findings. So I'm gonna present it now, and definitely this is not the only way. I always tell you guys that this is not the only way you have to present a case of carcinoma stomach. You can certainly change it, but this is just sort of a guideline for you guys, especially for the third years, fourth years, and fifth years, and any postgraduate students who can also add more important information to this. So let's start. So at first, we are going to start with the particulars of the patient. Now, particulars of the patient, why these are very important, we know this. Within the particulars of the patient, you will usually see the patient is above 40 years old. More commonly, you'll see the patient is above 50 years old. This particular patient I'm talking about is actually about 67 years, if I remember him correctly. Sex is male. Now, you will always see that most of the solid organ malignancies are more common in case of males. Certainly, females can also have it, and I have seen a lot of females having carcinoma stomach, but I have seen more male patients than female patients. Religion, not very important. Occupation, sometimes may be important, especially uh, people who are more were affected by radiation, who has usually, for example, if you remember that in Hiroshima and Nagasaki, where many of the population who were present during the Second World War, who had suffered from high levels of radiation exposure, had different types of malignancies, including carcinoma stomach. Of course, carcinoma stomach is very common in that part of the world, especially Japan. If you know that Japan has the one of the highest incidence of carcinoma stomach, not because it was Hiroshima and Nagasaki. It's mainly because the food habit they're having. I'll come to that. Okay. Now, chief complaints, it is very, very important. This is actually one of the most important parts of your presentation. From the chief complaints, you actually guide your examiner what you want the examiner to understand. If you want him to be, if you want to think it's a case of obstructive jaundice due to carcinoma head of the pancreas, you'd guide him accordingly. If you think it's a case of obstructive jaundice due to cholelithiasis, you guide him accordingly. It is from the chief complaints the examiner starts to imagine which way the student or the examinee is going. So it's very important. Now, in case of malignancy, this is actually the way I have written it. You will not find this in any books, but this is the thing I usually try to remember. What are the presentations of any malignancy? Now, remember, any malignancy at its earliest stage usually is asymptomatic. Same for carcinoma stomach. At the very earliest stage, they're asymptomatic patient. You actually has no sign symptom at all. Then the patient starts to have some symptoms. That is the early symptomatic phase. Now, again, let me remind you that this is not written in any book. This is the way I usually remember the signs symptoms of any malignancy. The early symptomatic, what happens? The earliest symptoms are new onset dyspepsia. Dyspepsia. New onset dyspepsia after the age of 40. The patient, imagine that this patient has no dyspepsia. Now, what is dyspepsia? It is a spectrum of upper abdominal symptoms, mainly caused by indigestion. There may be excessive gas formation. There may be abdominal discomfort after taking food. There may even be nausea. There may be reflux. In fact, if you see, the commonest causes of dyspepsia are cholecystitis and sometimes reflux gastritis. But also in case of carcinoma stomach, you may get nausea. The easiest thing to remember about dyspepsia is indigestion. The sign symptoms that are produced due to indigestion. Indigestion. So there can be abdominal pain, upper abdominal discomfort, excessive gas formation after taking food, nausea, vomiting, loss of appetite, all these things. There's a spectrum of symptoms that the patient complains of. This is new onset dyspepsia above the age of 40. Patient previously had no symptoms, but suddenly these symptoms have started. This is early symptomatic phase. When the patient goes into an advanced phase, you may find there may be an abdominal lump, or there may even be obstructive features. Usually, abdominal lump is a sign of very advanced disease, and also abdominal lump is also a sign of incurability. That means no matter how good the surgery is, the lump is so large and probably it has been there for such a long time that we think the cancer has already spread locally and distally. So this is an advanced phase, maybe T3 or even T4. I will come to T3 and T4 in the next slides. Emergency. There's the obstructive features. For example, there may be nausea and severe vomiting after taking food. That is gastric outlet obstruction. Or even maybe there may be bleeding in the form of hematemesis or even melena. But hematemesis is actually a feature of emergency in case of carcinoma stomach. But melena is a common symptom, but it is not necessarily a it's an emergency symptom. Metastatic features. What can be one of the metastatic features? Patient may have metastasized into the lung, right? There may be dysphagia, there may be chest pain, there may be hemoptysis. Then there are non-metastatic features as well. For example, if you remember the Trocheus sign or migratory thrombophlebitis. Migratory thrombophlebitis, that's a non-metastatic sign. I will discuss this in the next slides. Okay, so history of present illness. This is one format you can follow. You can certainly change it into your own. According to the statement of the patient, he was reasonably well about 5 months back. Remember, this 5 months means not that the patient is having this disease for the 5 months. This is for the 5 months back, the patient has noticed his problems. The patient may be having this problem for more than 1 year, as because initially the patient was in asymptomatic phase. Right? If you remembered our previous slide. Then he felt pain in the upper abdomen, which was gradual in onset. Patient may describe these features of dysphagia in various manners. Pain is one of them, which was gradual in onset, dull or burning or dull aching in nature, moderate in intensity, non-radiating, lasting for hours, aggravated after taking food, relieved by antigastric medication. Now, if you look at this, these features are very similar to peptic ulcer disease. Now, that is one of the biggest problems with with carcinoma stomach, because initial features are very similar to peptic ulcer disease, and patient takes antigastric medications and they are relieved. So patient think this is probably, even the doctors think this is probably a case of peptic ulcer disease, and they lose precious time which could have been used for an early surgery, but which is lost. And eventually, the patient presents to the doctors in an advanced or inoperable stage. For the last 2 months, he's suffering from vomiting. Now, vomiting, that means it's an obstructive feature. This is an obstructive feature, which is projectile in nature. One of the cardinal features of gastric outlet obstruction contains undigested food materials of the previous meal, sour in taste, not bile stain. That means the obstruction is above the duodenum, or at least the second part of the duodenum, and occasionally blood stain. Now, this is a dangerous feature, it's a red flag feature. He also has significant unintentional weight loss of about 10 kgs in the last 3 months. Why? Due to loss of appetite to all types of food. Now, the patient do not feel hungry, and as a result, patient is not taking food. The loss of weight may be due to the loss of appetite, due to loss of reduced food intake, but mostly in case of malignancy, there is a cytokine that is called cachectin, which is produced by the cancerous cells and which causes severe cachexia, especially upper abdominal malignancies. He feels tired all the time. Why? Because lack of food intake and unable to continue with his daily activities. His bladder habit is normal but contains an occasional black stool, meaning melena. He has no symptoms of jaundice, headache, cough, hemoptysis, or bone pain. That means he has no metastatic features. Past history, treatment history, or medication. Now, he has been suffering from peptic ulcer disease for the last 10 months, last 10 years. Previously, his symptoms, excuse me, previously his symptoms usually lasted for 1 or 2 months. But for the last 5 months, his symptoms are not subsiding, rather, they are getting worse. Now, this is very important. The patient has been suffering from peptic ulcer disease, probably. Now, you remember we have talked about new onset dyspepsia. That's also correct. Or sometimes the patient may be suffering from peptic ulcer disease as well. In which case, how can you differentiate between the previous symptoms and the newer symptoms? What you'll see, the newer symptoms are worse, and they do not subside with medication. If you give them medication, previously used to give H2 blockers or proton pump inhibitors, and they were very good. But now they are no longer working. So this is something that tells you that something has gone wrong, something has changed. So this is very important, that if a patient comes to you with a long history of peptic ulcer disease, you take this history. You can ask the patient that, Mister, you have been having this problem for the last 10 years. Why did you come to us right now? And the patient will give you a similar feature, that for the last 10 years, I had this problem. It was mild symptoms, and I used to take some medications and used to go away. But for the last few months, it's getting worse, and the medications are not working. That's why I came to you. Pernicious anemia, atopic gastritis, these are patient won't be able to tell you. So just remember, this is one of the pregastric, precancerous, uh, precancerous problems that the patient may have. Previous gastric resection, this is also something that has a predisposition towards gastric malignancy. And then in general, you'll take history of any hospitalization, surgeries, medications, long-term illness, and other things. Any medication the patient is taking, allergic history. This is for all diseases. Personal history. Now, this is very important. If you remember what we have talked about Japan, that they are having high incidence of carcinoma stomach. Why? Because they take a lot of salted food, smoked food, and food that uses a lot of preservatives. You remember nowadays we also get the sushi and the sashimi. If you remember, I don't know how to sashimi, Shimi. More maybe this is the, or maybe this is the name pronunciation. Remember the sushi and the sashimi that we take nowadays in our fast food, and we are very fond of it. These things are salted, sometimes smoked, and contains preservatives, so they can cause cancer. Now don't be scared and stop taking sushi and sashimi. They're also very nutritious, but make sure that they have been processed in the correct way. Then I don't think there should be a lot of problem. And also we are not taking them every day, so I don't think they will cause cancers. But because the Japanese people are taking all this food for a long time, there is a chance of malignancy. And as always, smoking and alcohol. This always has predisposition for malignancies. Family history very important. This is any familial malignancy. This is very important. Ask the patient whether the father or the mother or anybody in the family had any malignancy, especially carcinoma stomach. Socioeconomic status, it can be upper, middle, or low poor people, lower class people. Anybody can be having this problem. But in Bangladesh, they say that Helicobacter pylori has a predisposition towards CS stomach, and this is more common in lower class people. I'm sure anybody who takes outside food, anybody, in fact, I think everybody in Bangladesh has Helicobacter pylori in their stomach. But if you go through your Bailey and Love, they have said clearly that in developing countries, it is mostly seen in case of lower class people who has been taking this, and in their cases, usually the cancer happens in the distal part of the stomach due to H. pylori. And any disease which is not associated with H. pylori has cancer in the upper part of the stomach. Food habit, poor food preparation and water. Immunization history as well you should take. General examination. Now the patient is ill looking, body build will may be cachectic. Nutritional status, low BMI, very low, maybe something like low, less than 18, maybe 15 or something like that. Patient may have anemia. Why may the patient may have anemia? Because the cancer may be an ulceroproliferative disease. The cancer may be an ulceroproliferative disease which causes loss of blood. There's always a little bit of bleeding going on from the ulcerative surface. Jaundice may be present. When? May be present in case of very advanced malignancy or in case of hepatic metastasis, very rarely. But if there's advanced malignancy, advanced lymph nodes are involved, especially in and around the porta hepatis. Then the patient may have jaundice. Edema may be present. Why edema may be present? Due to nutrition, lack of nutrition, due to hyperproteinemia, the patient may have edema, pedal edema if you see. Cervical lymph nodes, left supraclavicular lymph nodes or the varicose lymph nodes may be enlarged. Very important finding if you have a carcinoma stomach. Even if it's not a finding, if it is not present, the examiner will ask you if you have checked it. Dehydration, the patient has been vomiting for a long time, may have dehydration. Pigmentation, sometimes acanthosis nigricans, there is another something like that that can happen in case of carcinoma stomach. Now this is the varicose gland. This is the varicose gland. This is the left supraclavicular lymph node. How does this happen? The thoracic duct, which carries, which drains the lymphs from all over the lower part of the body and even the right side of the right lung, they comes over here, and in that case, the supraclavicular lymph nodes may have metastatic cells. If the cells of the cancer reaches into the supraclavicular lymph node, then they become enlarged. They're hard and enlarged, sometimes fixed. Now, this is a common question. I have seen many of you are not being able to answer this question. If you look at this picture, this is the lung, this is, and this is the side of the lung. Now, the lung is drained by left bronchomediastinal lymph nodes and the right bronchomediastinal lymph nodes. The upper limb is drained by the subclavian lymph nodes, and the head neck region is drained by the left jugular lymph nodes. So they drain into the right lymphatic duct in the right side. But on the left side, they drain into the thoracic duct. Now, the thoracic duct also drains the lower part of the body. The lower part of the body meaning the trunk and the lower limbs. So any disease, especially malignancy, which happens within the abdomen, will also be drained through the thoracic duct. And as a result, the left supraclavicular lymph nodes, which are present over here, may be enlarged. This is called acanthosis nigricans. It's an abnormal type of pigmentation. Then there is migratory thrombophlebitis. I actually don't know why acanthosis nigricans happens. I have checked it on many websites, but none of this could answer it. If you guys find it out, please let me know. Now, Troche syndrome, migratory thrombophlebitis occurs because of pro-inflammatory cytokines. Sorry. Or prothrombotic cytokines. So there are a lot of prothrombotic cytokines secreted by the tumor, which causes migratory thrombophlebitis. Why is it called migratory? Because sometimes the thrombophlebitis is over here, sometimes it's over here. That's why it's called migratory thrombophlebitis. Okay, so we have done the general examination. Now we are going to come and do the local examination or the abdominal examination. So on inspection, what will you get? Usually the patient is cachectic. So may get a scaphoid-shaped abdomen. The abdomen may shape like this, scaphoid. Or if the patient has ascites, abdomen may be protruded, something like this, due to ascites. There may be a lump present. For example, in this patient, there is a lump. It's a visible lump, as you can see. Sister Joseph nodules, usually in and around the umbilicus. There actually mostly happens due to the ligaments that are present. For example, the falciform ligaments. Usually what I've heard is it's through the falciform ligament this thing comes. It can also come from the median, if I remember, the allantoic ligament. I don't remember exactly the name of this ligament. Usually it follows the falciform ligament. For example, this is the carcinoma stomach. So there may be malignant deposits through the falciform ligament. It usually reaches the umbilicus. Okay. So on palpation, you check for tenderness. If there's any palpable lump, you note down its features. Liver may be palpable, fluid trill present, or succussion splash. Succussion splash usually will be present in case of gastric outlet obstruction. Remember, in case of carcinoma stomach, before gastric outlet obstruction happens, usually the patient goes to the doctor nowadays. Previously, we have seen a lot of patients with gastric outlet obstruction in case of carcinoma stomach as well. When to do the succussion splash? At least 4 hours after food. right? Don't do it right after taking food. Okay. Percussion, shifting dullness must be checked whether there is any ascites or not, or skull to percussion, it's not necessary. Biorectal examination must be done to check for rectal shelf of Bloomer. What is this? Rectal shelf of Bloomer means any pelvic deposits are present or not. If there is any pelvic metastatic deposits, which may be palpated as rectal shelf of Bloomer. So, salient features. How to write the salient features? Very important. It should include the important positive and important negative findings. So this is how I write it. Usually it should not be more than 5 or 6 sentences. But yes, of course, if there's more important information, you can add more, but it should be as small as possible, but should give as much information as possible as well. For example, if we try to write salient features in case of a patient of carcinoma stomach, it should be something like this. Mr. X, 50 years, a farmer from Borishal, was admitted with the complaints of dyspepsia, hematemesis, severe anorexia, and significant weight loss for 3 months. Certainly, the duration may vary. Accordingly, you can write it. The dyspepsia may be a new onset dyspepsia. He has melena, but no metastatic features, and he has been suffering from peptic ulcer disease for last 20 years. So if he has been suffering from peptic ulcer disease back or 3 months back, then it can be a new onset dyspepsia. Palpable varicose gland. That means a very advanced feature. Advanced feature. Now, if you find palpable varicose gland, you can omit this. That there's no metastatic feature because this is a metastatic feature. So then you can leave that. If you don't find any metastatic feature in your clinical examination, you can certainly write that. He has a non-tender mass in the epigastric region extending into the left hypochondriac region, which is about 10 into 8 centimeter hard and fixed. So fixity is another bad sign. In fact, any palpable lump, any malignant lump which is palpable, any intra-abdominal lump which is palpable is a sign of incurability or sometimes even inoperability as well. Provisional diagnosis. What should be your provisional diagnosis? Certainly carcinoma stomach. It can be advanced. It can have gastric outlet obstruction. You can certainly write which part of the stomach it is involving. For example, if you think there's gastric outlet obstruction, then you can write carcinoma of stomach involving maybe the pyloric or the antral region. Or if the patient gives you history of dysphagia, that means the upper part of the stomach, somewhere around the cardia or near the esophagogastric junction. Esophagus and gastric junction has been involved. Okay, so what are the differential diagnoses? Always remember, according to your clinical findings, it's very, very important. It can be peptic ulcer disease with gastric outlet obstruction, maybe a lymphoma if the patient is having fever, maybe GIST, which is uncommon, but you will see many cases of GIST in your clinical life. Peptic ulcer disease, we have discussed this. See a transverse colon. Now, this is very important because even the cancer of transverse colon may be palpable in the very same region, in the epigastric region, maybe. And if you don't find any upper intestinal features, maybe this is a case of carcinoma transverse colon. Even advanced carcinoma gallbladder. Don't write it. Don't write this. Don't write this. But remember, even symptoms from diseases which looks absolutely different or unrelated may have very similar features, because I have seen one case which I also was I have taken clinical history and I thought it's a case of carcinoma of stomach, but later came out to be a case of advanced carcinoma gallbladder. So this can happen. Just keep your eyes open and just don't have a narrow mind, have a wide mind, and think that, also be ready to think outside the box. But at least in your exam, don't write this. So, investigations. The number one investigation, what we should do is, first we have to confirm our diagnosis and exclude our differentials. So we do an endoscopy and we take biopsy. Now remember, if you do an endoscopy, you certainly see the lesion. For example, this is the lesion, let's say. So how you take the biopsy? You divide it into four quadrants. You take two samples from each quadrant, right? That means eight samples. And from the center, you take another two. So these are the 10 samples that you should take. You must take an adequate amount of biopsy. Now remember, if you think that even after 10 biopsies you have not been able to take successfully enough tissue, then take more tissue. Just don't, what you have to do is to take enough tissue to make a definitive diagnosis. Then we go into staging. Certainly, we go for ultrasound, chest X-ray, and liver function test. But what is more important is CT scan of the whole abdomen and chest. These are the investigations now worldwide accepted as the ideal investigations for staging purposes. So you can certainly say this, but due to expense, due to these are, as they're very expensive and not always available in our context, these three investigations should be the first line investigations. Certainly, serologic markers, many of them, this is particularly a new one, which is usually elevated, but they have low sensitivity and specificity. So they have always have a supportive feature, not that they, if they are elevated, then they are definitely there. And lastly, you have to go for fitness for diagnosis. Okay, today I don't think we'll have enough time to discuss all of it. I will only confine myself to the clinical aspects of carcinoma stomach. Theoretically, maybe another day we can discuss. Now, pathological classification, this is also theoretical, but I think you have to know this. The Lawrence classification, very, very important. This is the two types of carcinoma stomach, the intestinal type and the diffuse type. The diffuse type may be familial. Intestinal type comes from gastric atrophy, intestinal metaplasia. Diffuse type usually happens in the younger age group. And they're the bad, these are not very good cancers. None of the cancers are good, but these are the worst. They're poorly differentiated cancers. And their intestinal gland formation takes place in case of intestinal type. There's more hematogenous spread, more transmural or lymphatic spread. That means chances of metastasis are also present in both of them. And other things, these are not very important. You don't have to learn all of this. That means that diffuse type of malignancy, these are the worst. These are poorly differentiated cancers, happens in the younger age group, maybe familial. And usually in case of diffuse cancer, you have to go for total gastrectomy. Depth of invasion, very, very important. Depth of invasion, early gastric cancer and advanced gastric cancer. Early gastric cancer means involves mucosa or submucosa with or without lymph node involvement. That means it only takes into consideration whether the depth of the invasion, not the lymph node metastasis. The patient may have lymph node metastasis, but regardless, it will be if the patient is involving, and if the cancer is involving only mucosa and submucosa, it's an early gastric cancer. And advanced gastric cancer means through the musculus propria. That means this has a worse prognosis, advanced gastric cancer. Now, the early gastric cancer, the Japanese classification, this is the protruded type. This is the excavated type. and these are the superficial type. It can be superficial elevated, superficial depressed, or deep. And deep, if you remember, the early gastric cancer, these are the early gastric cancer. These are the advanced gastric cancers. The number one is protruded type, typhoid type. Number two is the ulcerative type. Number three is ulcerative type. Number four is diffuse infiltrative. This sometimes is also called, I'm coming to the next slide. Uh, barium meal X-ray. It's not very important, but if you look at this area, this particular area, you'll see that there's a persistent filling defect. Persistent filling defect over here. You can also go for endoscopic ultrasound, not very important. These are usually done to see the early gastric cancers, not very important. Lymph node metastasis is very important, very important. Now remember, the carcinoma stomach has a lymph node. If it has a lymph node metastasis, and for oncological clearance, for that purpose, you must also clear the different tiers of lymph nodes. At least the first tier of lymph nodes must be removed. For example, if you look at this, the N1 lymph nodes, that means the perigastric lymph nodes. The perigastric lymph nodes. What are the perigastric lymph nodes? This is the right cardiac, the left cardiac. Then this is number three is nodes along, what is this? This is the lesser curvature, right? So these are the node along the lesser curvature and also the nodes along the greater curvature. Now greater curvature can be divided into right gastroepiploic lymph nodes, left gastroepiploic lymph nodes, and lymph nodes along the short gastric arteries. And lastly, the suprapyloric and the subpyloric or the infrapyloric lymph nodes must be removed. These are the N1 lymph nodes or the perigastric lymph nodes. These must always be removed during any malignant surgery, especially when you're doing a total gastrectomy. For example, if you're doing a partial gastrectomy, for example, the tumor is over here in the near the antrum, you have to remove the suprapyloric, the infrapyloric, and the lesser curvature lymph nodes, and the partially the greater curvature lymph nodes, especially along the left gastroepiploic vessels. These lymph nodes must be removed. This is the thing you have to remove if you're doing a lower partial gastrectomy. Then there are other tiers of lymph nodes. You don't have to know that. But remember one thing, in case of total gastrectomy, you have to remove all of these lymph nodes and also the number 7 lymph node, that is nodes along the left gastric artery. This also has to be removed if you're doing a total gastrectomy. Other lymph nodes, I don't think it will be necessary for you to know at any level, not even at FCPS level. But if you're in FCPS level, it's better to know that if sometimes somebody asks these questions, you should be able to answer them. Modes of spread, there are direct spreads, penetrates the wall, adjacent organs, especially pancreas, colon. If it advances into the adjacent organs, it's inoperable case. Lymphatic spread, the varicose nodes, the trochleus node we have discussed, blood-borne metastasis, liver, bones, lungs, commonly involved. Transperitoneal spread, anywhere in the peritoneum, especially into the pelvic region, the Kuchenberg tumor, or even the umbilicus, the sister Joseph nodules. We have already discussed all this. Now, this is a CT scan. What you can see is there is a abnormality over here, and which has also spread into the pancreas. So this is an inoperable case. Now, if you look at this, you see multiple liver metastasis. That means liver is also involved. You can see a lung metastasis over here. PET scan can be done. Usually, PET scan is done after the surgery. Before the surgery, it can also be done. But before giving chemo, sometimes it is done to check what happens after the patient has taken the chemo, to compare the results. It is quite an expensive investigation, not commonly done to all patients, and not also available. Now, the last investigation I want you to remember is the staging laparoscopy. This is an investigation you must always talk about, because this is the only investigation which can see peritoneal seedling. Peritoneal seedlings can only be seen by this investigation. And what does it mean? Peritoneal seedling means an incurable disease. That means no matter how good the surgery is, it has already the disease has already spread into so far of the body that it cannot be removed. The whole malignancy cannot be removed, and a curative surgery is not possible. So, confirmed diagnosis. What can be the confirmed diagnosis? Carcinoma stomach, or carcinoma stomach involving the antrum or the body or the pylorus, or any part, whichever part you have seen through the endoscope, with or without any metastatic feature. So we can say it's a case of carcinoma stomach involving the antrum with hepatic metastasis, if the disease is like that. So treatment plan, very important. Now, how you are going to treat this patient? Treatment is certainly going to be according to the staging, right? According to the staging, according how much it has involved, whether it is a localized disease or whether it is a advanced disease, right? So we have to do whatever decision that has to be done. This should be done through a multidisciplinary team, which involves a surgeon, the anesthesiologist, a oncologist, the radiologist, the pathologist. These are only some of them, and uh, other disciplines may also have to be involved. For example, a nutritionist must also be involved, because the patient is cachectic. Nutrition is very important as well for this patient. This is very important. Remember, the surgery is the only curative treatment, also the best palliation, also thus the most accurate staging. These are the important features why a surgery should be done at any cost. Very, very important. What is the goal of the surgery? What would you like to achieve? I would like to achieve oncological clearance. Now, what does this mean? Oncological clearance. That means you have to do en bloc removal. En bloc means together. Everything must be together, not piecemeal. Not piecemeal. Resection of the whole tumor. All margins should be negative. The proximal, the distal, the radial must be negative, and an adequate lymphadenectomy must be performed. That means usually we remove the N1 lymph nodes, right? Now, if you think the N1 lymph nodes are already involved, then you should do N2 lymph node as well. This is called a D1 surgery. This is called a D2 surgery. Remember this. Negative margins at least 5 centimeter. That means if this is the stomach, if the cancer is over here, the margin should be at least 5 centimeter in the unstretched 5 centimeter. 5 centimeter from the cancer. Certainly, if the cancer is around the pylorus, then you can remove it from the first part of the duodenum, because this cancer usually do not spread beyond the first part of the duodenum. And Then we go for the reconstruction. Now, if certainly you have removed a large part of the gastrointestinal system, but continuity has to be maintained. So a reconstruction will be necessary. So just let me show you what happens in case of, for example, let's say there is a cancer in the antrum or the distal part of the stomach. So what are the things that we are removing over here? We are removing the first part of the duodenum, 5 centimeter, 5 centimeter from the margins of the cancer, the regional lymph nodes. This whole part is being removed. Um, just give me a little bit of time. I just have to go into another mode. Sorry for that. Now, again, if this is the and let's say this is the duodenum and then the jejunum, and this is the cancer. So you resect it from here and then 5 centimeter from here, and then the regional lymph nodes must also be removed. So now let's see what happens. So we have removed this portion of the stomach. Now a continuity has to be maintained, right? How this continuity can be done? One way is to bring this part of the duodenum or the jejunum and attach it over here. Right. So now what can happen? The food can go from here directly into here, and the bile and everything and the pancreatic juice can go from here to here. This is a gastrojejunostomy. But what happens is the bile and the pancreatic juice sometimes can go into the stomach as well, and which causes different types of problems. So what we do is do another thing. We do not attach this part over here. Instead, we attach. It is slightly difficult for you guys, but just stay with me and you'll see it's quite simple. What we do is we attach it over here. So what happens? It looks like a Y. This is called Roux and Y anastomosis. This is the best anastomosis if you want to prevent all these problems. Now let's go into another part. Let's say now the cancer is involving another part of the stomach. Maybe the body, somewhere around here. So we remove from the first part of the duodenum, from the esophagogastric junctions, and also the lymph nodes to perform the oncological clearance, right? So we remove this. So we remove this. Now, so what do we have over here? We have the esophagus. When we have the small intestine. So what we do is we bring a part of the jejunum over to the esophagus. We do a esophagojejunostomy, and we anastomose this part with the distal part. So we again form another Y-shaped anastomosis called Roux and Y anastomosis. So, more simplified terms, let's see what does this look like. So this is what it looks like. Total gastrectomy, we have done it. We have taken this part and anastomosed it over here, and this part is anastomosed over here. This is a very beautiful picture. Just have a look at it and you'll understand everything. So this is called a subtotal gastrectomy because part of the stomach remains, right? Nowadays they say the partial gastrectomy, a distal partial gastrectomy. And this is a total gastrectomy. Roux and Y, esophagojejunostomy. This is an alternative reconstruction. This can also be done or this can be done. Both are absolutely okay. Now, if there is a case where I've told you that sometimes the cancer cannot be removed, cancer cannot be removed. It's a inoperable case or irresectable tumor. So we cannot do anything, but we have to do something about it. So we do a gastrojejunostomy. So you take the food and food goes over here. Now this is a palliative surgery. This is a palliative surgery. We know that the patient will not survive with this. So we are doing a palliative surgery for this patient. Maybe sometimes what happens is in this case, we do a palliative surgery, let the patient take some food, patient becomes healthy, nutritional status improves, patient takes the chemotherapy. And what happens? The cancer becomes smaller, and suddenly an inoperable cancer becomes an operable case. And then we remove it. And once you remove it, then the patient have a better chance of survival. So if you remember the extent of lymph node dissection, D1, D2, D3. If you remember, the lymph nodes are N1, 2, 3, 4, right? So if we remember, if we remove all the N1 lymph nodes, remember N block must be removed N block. That means this is a D1 surgery. If both N1 and N2 is removed, it's a D2 surgery. And extended lymphadenectomy, if N3 lymph nodes are removed, D3 lymph node lymphadenectomy. Then there's another resection. I don't think I have written it over here, but remember this: R0, R1, and R2 resection. R0 means total cancer has been removed. R1 means uh, macroscopically total cancer was removed, but microscopically some cancer remains. And R2 means macroscopically some of the cancer has remained. This is worst surgery. This is very bad surgery. You should at least try to do R1 resection. Best is R0 definitely, but if it's not an R1 resection, then I think the surgery is not a very good surgery. Okay, post-operative complications, the paralytic ileus, leakage, certainly there's anastomosis, leakage can be there, leakage from duodenal stamp, a devastating um, complication, which is very bad, very deadly, but sometimes patient survives as well. Cholecystitis, pancreatitis, stomal obstruction. I have seen quite a number of patients with this problem. Due to stomal edema sometimes, or sometimes we have then a very small stoma, and as a result there's an obstruction. Sometimes edema causes obstruction. It is quite it's not very uncommon. Early dumping, late dumping. What is early dumping? This is some of the vasoactive compound, as because the stomach is no longer there, so the food immediately reaches the intestine, and what it causes, it draws in water from the body, and as a result the patient's blood pressure may fall. So the patient may feel a little dizziness or even syncope may be happening. So this causes early dumping syndrome. And late dumping is due to reactive hyperglycemia. Reactive hypoglycemia. What happens is whenever food goes directly into the small intestine, especially glucose and other carbohydrates, they are immediately immediately absorbed from the intestine and into the bloodstream. What causes this? Causes increase in insulin, and this insulin, high level of insulin, causes sudden hypoglycemia. This reactive hypoglycemia is a result of late dumping syndrome. Bilious vomiting can be, it doesn't happen in case of Roux-en-Y gastrojejunostomy. Gastric stump cancer can always happen. Vitamin B12 deficiency. If you remember, we are removing the distal part of the stomach, which causes the intrinsic factors, which is important for vitamin B12 absorption. Osteoporosis due to decreased calcium absorption. Chemotherapy, radiotherapy is also necessary. Now, thank you for your time, guys. Oh, a lot of questions are there. Let me see. I will try to answer a few of them. Okay. I hope, let's see. Everybody is very happy with everything. I think everybody has understood. There is one question over here. What is advanced gastric cancer and how carcinoma stomach spreads? Very good question. If you remember, advanced gastric cancer, we have described this here somewhere, if I remember. According to depth of invasion, these are the two ways the cancers are cancer spreads. Cancer is staged early gastric cancer and late gastric cancer. Sorry, early gastric cancer and advanced gastric cancer. Early gastric cancer means mucosa and submucosa with or without lymph node involvement. Advanced gastric cancer, which you have asked, is into the which spreads. For example, if you remember, if this is the mucosa, this is the submucosa, and let's say this is the muscle layer, right? And this is the serosa. The cancer involving into mucosa and submucosa, this is early gastric cancer. Cancer involving the muscularis propria or even extending beyond the muscularis propria, these are all advanced gastric cancer. And how cancer spreads? Cancer spreads in various ways. For example, blood-borne metastasis may be present. For example, look at this. There may be a direct spread, the muscle layer, the serosa, to adjacent organs. There may be a lymphatic spread to the, if you remember, the lymph nodes N1, N2, N3, and N4. These are the lymph nodes. You see? These are the lymph nodes. N1, N2, N3, N4 lymph nodes. This is the lymphatic spread. And they can also spread into the varicose node. Then there's the blood-borne metastasis, commonly the liver, the lung, even the bones, and the transperitoneal spread. Anywhere in the peritoneum may cause ascites, Schwarzenberg's tumor, when they're deposited into pelvic organs, especially the ovaries, cystic nodules in the umbilicus. So, thank you for your time, guys. I hope this was of help. If you need any further discussion, I would certainly love to discuss more about it. I am very happy that you have given compliments today, and hopefully this has been of help. I certainly would like to do another class on carcinoma stomach if you guys request it, especially on the theoretical aspect. We have more into the discuss more into the clinical aspects. Hopefully, we'll be doing that class very soon. I'm sure time is up for prayers. So thank you very much for your time. See you next, maybe in the next month. We'll see you again. Thank you, guys.